than happy to start. So it was a bit rushed, and I think everyone would agree that, but there was some really good stuff that came back. So in terms of initial referrals, we had a good conversation about that. We talked about some of the referrals coming through not being appropriate. Bisphosphonates were mentioned about them being treated in primary care, soft tissue coming through that could be treated again in primary care. There was variability in types of in the referrals, and we had a conversation about the numbers. And for some of the referrals that came through, it's impossible to see on the letter that was received just exactly what the patient was going to be like when they turned up in clinic. So we think it absolutely, from an ICS perspective, there's some more work we can do around that. In terms of the second point, we had a good conversation. We talked a little bit about collaboration and better working between primary and secondary care. We absolutely covered off the bits around. We talked about transient population. We talked about failed to attend. We also had a conversation about the amount of time it takes to triage some of the referrals that are received in secondary care as well, and how that takes clinicians away from doing the job of actually seeing and treating patients. We also had a bit of a run around each of the trusts about the size of the list and how they'd got on with doing their cleansing exercise, and there's a bit of variability around that as well. And we were keen to maybe do a bit of work trying to, for those that have huge lists, trying to help support doing some activity around just making sure that everybody on the list should be on the list. The third question about utilising enhanced skills that exist in primary care. There was a good discussion about that, and I think overwhelmingly the group agreed that was something we should pursue through the managed clinical network that we're going to put in place, and look at that. And I think some of the stuff that we'd heard from the speaker early on, Chris talked about some of the things that we're doing in their area, and we're going to emulate some of that. I think we have a very vibrant and healthy tier 2 service that exists that we can build on in Lancaster, South Cumbria. We're keen to exploit those skills where we can. And of the final question about capacity in secondary care, we had a conversation. It seemed to be dominated by something that's going on within our ICS, where there's something come down about all trusts having to get back to 120% of their previous July figure, which was going to be a bit of a challenge, but with I say ready to meet that challenge. That's what we were talking about anyway. So that's a kind of a bit of a whistle-stop tour of the things that we discussed in our group. I'm going to type up some notes, and I'm more than happy to circulate them with everybody else so they can see what we did in our ICS. So there you go. Over to I think this feels like I'm doing one of those Eurovision bits. Who's next? It's not Luxembourg, is it? Is it Greater Manchester or Cheshire and Mersey?
I think it was going to be Greater Manchester. And was that you, Marie?
Yeah, that can be me. So I'll just hit on some of the key points. With regards to the initial referral, they did feel that there were inappropriate referrals coming in. I've just seen a comment come in the box there with regards to it is harder to reject a referral and the work that goes into that. So there is some more work that can be done with regards to the standard of referrals coming through and the quality there. We had some discussions around any kind of review of the pathways needs to include the whole pathway, starting from the actual patient referral. We had some discussion around the types of referral that come through with regards to electronic referrals, which it has been established. The other area of discussion with regards to the waiting lists, there's a lot of different techniques being used across the patch. Bolton in particular have had extra clinics in addition to clinics that they've already had to see their long waiters. Many of them staying on the waiting list without them getting treatment or having their plan changed. And there's also been some other techniques of writing to patients on the waiting list to see whether or not they still want to engage with the process, and also some telephone assessments for patients that have been waiting for a long time. Various different issues raised with regards to safeguarding, which needs to be borne in mind when using these techniques and removing people from the waiting list. With regards to the third area around the primary care and utilising their skills, it was felt that contracts was an issue. So we had quite a lengthy discussion with regards to the types of contracts out there. But again, it's an area that could be looked into much further to get a better understanding and see what the opportunities are there. And finally, with regards to the capacity, we didn't really have much time to discuss that. It would have been nice to have seen some more of the thoughts around what the barriers, but a good summary was given by Chris around recognition. Funding and contracts are barriers, and also the workforce. So in some trusts, they're having the theatre capacity, but not the theatre staff to support the lists. Okay.
That's great. Thank you very much. And yeah, and finally, coming Cheshire and Merseyside.
Yeah, sure, that's me, Neil. So we had some really interesting discussion, lots of contribution from different people, different providers, and commissioning representative in our group. So around the first question on initial referral and allocation, I think the discussion sort of veered towards the referral management system. I think there was some sort of consensus from providers that it doesn't really do what it needs to do for them at present. And that's largely down to the fact that it's historic, and they've had quite a job trying to get that to change. So we've had a bit of an offer of support from commissioning there to engage with that whole process again. With respect to waiting list cleansing, so Tim explained that they'd started that in June prior to the national guidance and spent a month going through it all. Seemed to be working well in terms of identifying the urgents, soons and routines. One point that was made is that it's kind of an ongoing process, so you can do it once, but then you have to return to it, don't you? And things have changed. Around the utilising clinical skills, doing more in tier 2 and utilising clinical skills. The general consensus around this really is that there needs to be greater sort of flexibility and sustainability in the way we're using specialists across our system, so that the way things, it does have potential to improve if they're contracting, if we're using longer contracts.
I've lost you, Anna.
Apologies for the interruption there, barking dog. So lost my thread there. So there is potential, but we probably need to look at the way things are contracted presently to allow for more flexibility and sustainability. And then on that last question there, which was around widening clinical capacity in primary and secondary care, I think there was some suggestion that we need to be aiming for more parity of what is provided. If an example was at St Helens, and they're currently referring sort of 10 to 15 patients per week to Aintree because they're not commissioned to do the GA stuff, whereas they could be doing that if they were commissioned to do so. We had Anne from Aintree saying that they're working up towards 70% capacity. I think they have a backlog for the more complex things, but there is variation between the hospitals. And the major issues there, the major sort of challenges to getting back up to capacity were identified as staffing in operating theatres and clinics, and also staff leaving. Thanks, that's probably Cheshire and Mersey covered.
Thank you very much, Anna. So if the facilitators could maybe write up the findings, and then we could share that around the group along with the various things that we promised that we would share. Donna, if you could pull all that together. Steve, I'm going to ask you to sort of close the meeting. I'd like to thank everybody for their input today, especially the speakers, and give you the tricky question, Steve. Where do we go next?
Well, I'd also like to thank the speakers, particularly Chris Bell, for not just for his excellent talk, but also for sharing his wisdom in the conversation. I'd particularly like to thank the delegates. I listened to the Lancashire and South Cumbria one, and I was very encouraged really by the level of positivity, collaboration and learning. Where do we go next? Well, we'll definitely share the slides as we've promised to do. We'd really appreciate feedback. I think the main place we go next is getting those managed clinical networks established and functioning, and we've heard really what we should be aspiring to from Chris, haven't we, really? and I'll be doing my job to try and get the resource required for that. The other place we could go next is to repeat this, and I would suggest it's a case of when rather than if. And perhaps when you provide feedback, just indicate whether 3 months, 6 months would be a reasonable length of time, and in particular what you'd want to see on the agenda, really. So that's probably all I've got to say, really. I'm sure next time we need to factor in a little bit more time for the breakout sessions, don't we? But we, like everyone else, we're continuing to learn. So thank you, everyone. Hope you get back to your afternoon commitments in time, and hopefully see you again.
Thank
Thanks,
you.
Steve.
Bye.
Thank you, everybody.
Bye.
Good afternoon.